Now we will discuss the ECG of a person presenting with acute severe chest pain to the emergency department. So you know what are the possibilities to be thought of and excluded in such an ECG. This ECG shows good standardization, as you can see here, with a square rectangular pulse. Then you can see it is sinus rhythm and the rate is a little over 75 because there are nearly 20 millimeters between two R waves or two P waves. Every QRS is preceded by a P wave, and P waves are upright in 1, 2, 3 and almost flat in AVF. This will qualify for a sinus rhythm. PR interval is near the upper limit of normal. PR segment doesn't show much of a depression. Then QRS complex appears to be slightly wide but not significantly wide. Here you have a Q wave, 40 millisecond Q wave, which is more than 25% of the amplitude of the ensuing R wave. That is in lead 3. But Q in lead 3 alone may not be that significant, but you have a Q, pathological Q in AVF also. Lead 2, there is not much of a Q wave. Then the gross finding, if you can find out here, is gross ST segment elevation. You can see it in 2, 3 and AVF. The ST segment is concave upwards and the T is also upright. Concave upwards ST segment is merging with the T wave, ascending limb of the T wave. Such an ST segment elevation is often used to be asked as an MCQ in the entrance examinations. This is known as the Pardy's sign, described long back in early part of 20th century. I think it was in 1920 or so. Pardy's sign of acute myocardial infarction. So you have Q and ST elevation with upright T waves. Those will qualify for a hyperacute phase of acute myocardial infarction, the two of the inferior wall. Then there is some ST elevation in V6 also. So part of the lateral wall may also be involved. But the other leads which reflect lateral wall, that is lead 1 and AVL, show ST depression. So this could be a reciprocal change for this ST elevation in inferior leads. You know that anterior wall infarction will have reciprocal changes in inferior leads and inferior wall infarction will have ST depression as reciprocal change in the lateral leads. But you cannot be very sure that there is no ischemia in this territory. It has always been debated whether this represents ischemia at a distance or truly just a reciprocal change. Anyway, change has to be noted. But there is a disparity between V6 and AVL. Now, inferior wall infarction, commonly it is due to right coronary occlusion. It could also be due to left circumflex occlusion. Especially since you see this ST elevation in V6, you have to think about it. A simple way to differentiate is you look at the ST elevation in lead 3 and lead 2, which is more. Here, obviously, ST elevation is significantly more in lead 3 than in lead 2. So, more of ST elevation in lead 3 would indicate right coronary occlusion, while if it is more in lead 2, it would suggest left circumflex occlusion. Then slight prolongation of PR interval could be an indication that AV conduction is getting affected, but this is not much of a prolongation, hardly just filling up the upper limit of normal of the PR interval. So this patient with ST elevation myocardial infarction hyperacute phase needs early coronary angiography and primary angioplasty if feasible. That is the importance of recognizing ST elevation myocardial infarction. When primary angioplasty is not feasible, you may consider thrombolytic therapy if there are no contraindications for thrombolysis.